some issues for the evaluation of non-inferiority trials. This presentation is based on our publication in the Journal of Comparative Effectiveness Research. The outline of this presentation. I will first introduce the background of this study, and then I will present 14 questions. Following an explanation of the 14 questions, we provide a brief discussion of how to review historical data for non-inferiority trials. Finally, we demonstrate the use of the questions using a non-inferiority trial on intraoperative radiation therapy for early-stage breast cancer as an example. I will start with the background. A superiority trial aims to demonstrate that one treatment is better than another treatment or placebo. Although most clinical trials are superiority studies, a non-inferiority trial is more suitable in some situations. For example, since standard therapy protocols for some diseases have been well established, it is often not ethical to use placebo-controlled superiority trials to demonstrate the efficacy of new therapies. Therefore, researchers can conduct a non-inferiority trial to assess whether the new therapy is at least as effective as the standard therapy. Designing a non-inferiority trial can be quite challenging. Not surprisingly, the quality of non-inferiority trials is often not satisfactory. Two systematic reviews revealed that 83% and 90% of published non-inferiority trials concluded non-inferiority for the experimental therapy. Although one explanation for this trend is potential publication bias. Poor study conduct, such as high patient attrition and low patient adherence rate, may introduce biases that lead to an incorrect conclusion of non-inferiority. We have proposed 14 questions to assess the non-inferiority evidence between the experimental and standard therapy in non-inferiority trials from the perspective of decision makers. Instead of presenting guidance on the study design of non-inferiority trials, the aim of these questions is to critically appraise non-inferiority trials and support the proper interpretation of study results. These questions are used to evaluate both the primary and secondary outcomes of non-inferiority trials to provide an overall understanding of treatment effects and the level of uncertainty of the findings. To conclude non-inferiority conceptually is to synthesize evidence from both the current non-inferiority trial comparing experimental therapy with standard therapy and historical data comparing standard therapy with placebo control. Therefore, in principle, readers should explore external data sources to validate the current non-inferiority trial. Every question can be scored as yes, no, or unable to determine. Question 1. Was the rationale for conducting a non-inferiority trial established? The rationale for conducting a non-inferiority trial should be well established. Generally, before conducting a non-inferiority trial, there is evidence to show that the experimental therapy has a certain advantage over standard therapy. The experimental therapy is better than placebo or best care in clinical studies, and the efficacy of the standard therapy has been demonstrated. These criteria are likely not all explicitly stated in a single non-inferiority trial, so readers may have to seek additional information from other sources to answer this question. Question 2. Was the standard therapy properly selected? Sometimes there is more than one standard therapy. In this situation, the non-inferiority trial should use the standard therapy with the most consistent evidence, and ideally with the best efficacy. Question 3. Did the study select the appropriate effect measures and endpoints? The selection of clinical endpoints and effect measures impacts the determination of the non-inferiority margin and potentially the conclusions of the non-inferiority trial. Although there is no consensus on these issues, selection of the most commonly used endpoints and effect measures within the primary analysis of RCTs for a particular disease is recommended. Question 4. Was the study well conducted? Poorly conducted non-inferiority trials are likely to bias the results towards the alternative hypothesis, and may potentially lead to an incorrect conclusion of non-inferiority. Question 5. Were the expected benefits of the experimental therapy confirmed in the non-inferiority trial? Compared with standard therapy, the experimental therapy is usually expected to have some benefit. Although the aim of the non-inferiority trial was not to examine these benefits, the expected benefit of the experimental therapy should be reflected at least partially in a rigorously designed non-inferiority trial. If not, the value of the experimental therapy should be questioned, even if non-inferiority was successfully demonstrated based on the primary outcomes. Question 6. Was the magnitude of the non-inferiority margin justifiable? Authors should report the method used to determine the non-inferiority margin in the non-inferiority trial publication. When the experimental therapy has important advantages over the standard therapy in other aspects, such as lower risk of severe adverse events, it may be justifiable to accept a wider non-inferiority margin for efficacy. Question 7. Was the assay sensitivity presented in the current non-inferiority trial? The standard therapy should present assay sensitivity, ability to distinguish an effective treatment from placebo, in the non-inferiority trial. If a non-inferiority trial includes 3 groups, experimental therapy, standard therapy, and placebo, the presence of assay sensitivity can be assessed directly within the trial. Question 8. Was the observed risk in the standard therapy group close to the expected value? Due to improved disease management, the observed event rate in the standard therapy group is often less than the expected event rate that is usually estimated from historical data. A simulation study has demonstrated that non-inferiority trial conclusions are highly sensitive to both effect measurements and the underlying risk in the standard therapy group. In an extreme situation, such as when no event occurs in either study group, the efficacy of the experimental therapy versus standard therapy should be interpreted as inconclusive rather than identical. Question 9. Was the follow-up duration adequate? Authors should understand the risk profile of the disease being investigated, and the high-risk period for the event of interest should ideally be within the follow-up period. Question 10. Did authors conduct both intention to treat and per-protocol analysis? Generally, intention to treat analysis tends to minimize the differences between the experimental and standard therapies, whereas per-protocol analysis tends to reflect the maximum possible difference between the 2 groups, assuming random crossover and patient attrition. The per-protocol analysis alone may introduce bias. Demonstrating non-inferiority in both an intention to treat and per-protocol analysis provides the necessary assurance of non-inferiority. Question 11. Did the survival analysis adhere to the random censoring assumption? In early-stage cancer studies, it is not uncommon to select local recurrence as the primary outcome and to censor other more severe events, such as distant recurrence and mortality. For convenience, authors also often make the assumption of random censoring when analyzing time to event data. If the study censors oncological events, readers should compare the censored event rates between the 2 groups and check for adherence to the random censoring assumption. 12. Did the adjuvant therapy contribute to the clinical outcomes? In addition to the treatments being investigated, most cancer patients also receive 1 or more adjuvant therapies during follow-up. The adjuvant therapy would reduce the effect difference between the experimental and standard therapies. Since the effects of various therapies cannot be separated, when the effect of the adjuvant therapy is relatively large, it leads to more uncertainty in estimating the true difference between the 2 therapies. This slide shows the justification for the combined treatment effect from adding adjuvant therapy. We interpreted the mathematical justification as the adjuvant therapy reducing the difference between the experimental and active treatment. Question 13. Is the point estimate between the experimental and standard therapy close to no effect for the primary clinical outcomes? Readers should assess the following. Do the data allow you to make a conclusion of non-inferiority? Does the confidence interval fall within the pre-specified non-inferiority margin? And is the point estimate close to no effect between treatments, such as hazard ratio of 1 and risk difference of 0? Clinical relevance should be judged using best estimates. Question 14. Other than the primary endpoint, were other benefits of the standard therapy also obtained by the experimental therapy? Benefits of the standard therapy often extend beyond the primary outcomes. Thus, when the standard therapy has other important benefits in the long term, readers must be cautious of the potential uncertainties in similarities for secondary outcomes between the experimental and standard therapy groups. Review of historical studies for the evaluation of non-inferiority trials. Reviewing historical data is particularly important for evaluating non-inferiority trials that do not have placebo groups. A targeted literature search should be conducted to identify historical studies that compare the standard therapy versus placebo, and studies on the experimental therapy. Ideally, the targeted search would find the same, or at least largely overlapping, key articles as those used in designing the current non-inferiority trial. If not, readers should understand why the search results are different, and may conduct further searches as necessary. An example of the application of the evaluation list. Based on the answers from the 14 questions, we may conclude that the strength of the evidence supporting the efficacy and safety of new intervention is still very limited. An adequate number of patients would have to complete at least 5 years of follow-up before a definitive conclusion on the efficacy of the new intervention can be drawn from this non-inferiority trial. Here is the timeline of this article. Thank you.